So, hello everybody. Today we'll study some representative cases of lung cancer. Remember starting last time with the radiologic appearance. Yeah. So, let's have a look at the first patient's history. It's a 63-year-old woman with a smoking history, 8 packs per year. On examination, she has generalized edema, and her serum sodium level is quite low. So, the basic checking of this patient consists of a radiograph of the thorax, and we have some quite impressive findings here. How would you describe the left lung of the patient? You see that it's, yes? Yes, it has been actually, all the lung parenchyma appears to be replaced by a process, quite diffuse, and what is evident is that there is no air in the left lung. So what could that be? That could be a pneumonia or a bronchopneumonia. What about the right lung of the patient? What do you see there, highlighted by the sign? This appears to be a space-occupying process, and of course we are not sure whether it is benign or malignant. However, there is a sign that makes us suspicious that this process on the right lung may be malignant. Have a look at the symmetry of the lung fields, the right and the left, the upper, the middle, the lower. Is there a difference that you can tell me? Of course, we are not radiologists, but I think I see something that may make us think that the lesion of the right lung is malignant, is cancer. Have a look, symmetrical. Where are the high lung fields, the middle and the lower? Are they on the same level? Tell me, what do you think? What do you see as a difference? And let's think, how can this be justified? What do you think? What's the difference of the right lung fields, the lower one? Where do they appear to stop? Where do they appear to end? Yes. That's what my eyes see too. Your eyes see the same thing as my eyes. That's right. So that means that the right semi-diaphragm has gone up. How can this be justified? If the right part of the diaphragm is no longer, it cannot move. And what does it want so that it moves and helps the breathing process? What does it want to move? Any muscle. What does he want to move? Nerves. Can you tell me? Nerves. Nerves. So what can happen here? Perhaps, yes? Invasion of the pharynx nerve. Yes, this lesion may have invaded, so it's malignant. If it invades in the nerve and the nerve no longer functions, that's why the right side of the semi-diaphragm has gone up. It's not innervated any longer. So this appears to be a malignant lesion. Now, why on earth should a malignant lesion have these levels of sodium in the serum? And what is the consequence? Since the sodium is so low in the serum, what does the patient have? And is connected to this biochemical finding. Have a look at the patient's history. What does the patient have? I went to the festival University of Athens festival. And I sat there on the desk. How is that? Like the exhibition. I don't know how it is called. And they had the English medical brochure. This. I know. And I thought, you look very nice in the picture. Yeah, very nice. And you too. Hey. She looks very nice too. She doesn't listen to me, but tell her that she looks very nice in the picture. You are okay. You are on the second row. I saw it. So I know you all. I know all these students. Yeah, okay. So what we will say now? So those two low sodium levels are connected with which sign in the patient, which symptom of the patient? Looks, he has generalized edema. This has to do with the low, in this case, of course, with the low level of sodium. So how can this be justified? Which organ is responsible for the concentration of the sodium in the blood, and where else? In the urine. Okay, so it's the kidney. So is there a factor having to do with this inability of the kidney to produce urine? And so the serum sodium is very low. Does it have to do an imbalance between the urine and the portion of the sodium that is excreted? So this is low sodium. That means that, how can this be justified? Which hormone is responsible for this? Yes, that's the right, antidiuretic hormone. Because, and let's think, is it increased or decreased? Yes, because if we have increased antidiuretic hormone, urine is not produced, so the plasma, the content in the vessels is increased, and so the concentration becomes, you see, how low it is reduced. And this causes the edema of the patient. So this is antidiuretic hormone. When we see an hormonic imbalance in the body, we have to look the gland that is responsible for the secretion of this hormone, and in case of the antidiuretic hormone, which gland is responsible? Where is it located? The gland the endocrine gland that produces antidiuretic hormone. Yes, and I think it's in the posterior, in the posterior part of, so. But you have a check there, an imaging check, and there is nothing abnormal. So if the gland that is responsible appears normal, what else may you think? Taking into account now this radiological picture. Yes?
Tumor secreting.
Yes, probably. Since we said that this tumor is probably malignant because there is no longer innervation of the right semidiaphragm due to invasion of the respective phrenic nerve, then this tumor may also produce ectopic, not from the place where it is supposed to be secreted, of antidiuretic hormone, and causes this paraneoplastic syndrome to this patient. So let's have a look. This is probably small cell carcinoma because this is one main category of lung cancer, small cell carcinoma and non-small cell carcinoma cancer. And let's have a look at a biopsy. When we find these carcinomas bronchoscopically, they push the mucosal surface to protrude some way. It's not a tumor that has an exophytic or an ulcerating macroscopic image. So, what is the specimen that the upper figure shows? What is this specimen? This is cytology. So, he had the bronchoscopy. As we said in our previous lesson, he might have sent fluid and absorbed it back, they took it back, and this is a cytologic smear. What do the cells look like? What do these cells look like in the cytological smear? Which cells do they remind you of? What can they be? They have small, round nuclei, lymphocytes. However, they are bigger than lymphocytes. Their size is bigger. These are the cells of small cell carcinoma. And who can show me these cells in the biopsy specimens, in histology? Where are they? This is the cytology. This is the histological specimen. They took the biopsy. You see, is the lining epithelium abnormal in the biopsy specimen? Is the lining epithelium of the bronchus abnormal? Can you see where the lining epithelium is and where the tumor is in the biopsy, the lower image? So, is the lining epithelium is okay. There's no problem. It's cylindrical, respiratory type epithelium, this one. That's okay. However, below the basement membrane, which appears rather thickened, that's why it's so pink, there is an accumulation of all these small cells, no cytoplasm, not enough cytoplasm, so they are very dark staining, blue cells, and these are the cells of small cell carcinoma, and in order to be sure that this is small cell carcinoma, we have markers of neuroendocrine differentiation. Synaptophysin, chromogranin, because the progenitor cells of these cancerous cells are neuroendocrine cells which are dispersed randomly around the cells of the lining mucosal epithelium. Among these cells, there are some neuroendocrine cells, and when they become malignant, they give rise to this tumor, small cell carcinoma, and it has such increased mitotic activity and such increased apoptotic activity that when this diagnosis is made, surgery is not the primary consideration. You have to give chemotherapy because since these cells proliferate so quickly and have such a great apoptotic potential, if you give chemotherapy against rapidly dividing cells or against cells that have a great apoptotic potential, you can destroy them. So the disease can be controlled for some time, unfortunately, not forever, with these therapeutic drugs, these therapeutic selections you make. However, sometimes the patient may come and may have headaches due to spread to the brain. And of course, other sites of hematogenous spread are the bones, the brain. Yes, it's an ominous type of lung cancer and a very, very big category. It is related to smoking. And let's have a look at the history of this patient. It's another patient with small cell carcinoma of the lung. He had hilar adenopathy because probably the lymph nodes in the lung hilum were metastatically infiltrated. And here the serum cortisol was increased, not the ADH, as we saw in the previous case, the cortisol. How can this be justified as a paraneoplastic tumor? If you have increased amounts of cortisol in your blood, Cushing's syndrome is established. So, what do you think? Is there anything wrong in the hypophysis and produces an adenoma of hypophysis, increased amounts of ACTH and go to the cortex of the adrenal glands and produce abundant glucocorticoids? Is there a problem in the adrenal gland, an adenoma, a carcinoma that has this secretion of hormones, or is it a paraneoplastic syndrome from somewhere else? Which are the hormones that you always have to see comparatively to understand where the problem is? Is it the hypophysis? Is it in the gland, in the adrenal gland? Is it a primary lesion causing the endocrinic disorder? Or is it a paraneoplastic? You see the ACTH. Because if the ACTH is low, where is the problem of the source of this hypercortisolemia? If the ACTH is low, where is the problem? In the adrenal gland itself. If the ACTH is high, where is the problem? In the hypophysis. And in this case, now that it is a paraneoplastic syndrome, it has to do because these cells produce something that acts like ACTH. And it depends on what you use to detect ACTH. It functions like ACTH. However, it's not the same molecule. The action is the same as ACTH. So this is the case of small cell carcinoma. Now, have a look here. This is a tumor related to a large structure, so it has a central location. In this sense, it looks like small cell carcinoma. However, this is a lesion that has either an ulcerated surface or an exophytic component combined with an invasive one, because this lesion is also malignant. However, this is easily detected by bronchoscopy because it affects large bronchi, so the endoscope can reach these lesions, and you can take cells with a brush and have a cytological smear, or you can take a biopsy. But in case that this tumor is necrotic, then it will be difficult to take a biopsy because the tissue will be necrotic, and that may be a problem. In this case, brush material having on a cytological smear is the appropriate method to diagnose. So this is a squamous cell carcinoma, and you see that it can also be detected apart from bronchoscopy by the sputum cytology, because since this tumor affects main big bronchi, then cells may shed in the lumen and be taken away with the sputum. So if you have a cytological examination of the sputum, you may find the malignant cells of squamous origin. And let's see how they look like. And here is the genetic basis of this cancer. Here they are. This is on histology. This is the histological image of these cells. In which image do you recognize, do you identify squamous cell differentiation, and why? In one image, it's not so easy. In the other image, it's easy enough. What do you think? What do squamous cells anywhere in the body normally do? What do they normally do? Squamous cells either lining the skin, either lining the oral cavity, the esophagus, the cervix, the anus. What do they do? What do they know to do? Yes?
Production of keratin.
They keratinize. They produce keratin. So if we see keratin production in a tumor, which can either form keratin pearls, round structures, or single cells entering keratinization, this is called, the latter is called dyskeratosis, and it's a form of apoptosis. You see single cells, and their nuclei becomes pycnotic, and they shrink. They shrink. These are apoptotic cells, dyskeratotic cells. So where is the keratin pearl? In which image can you identify a keratin pearl? A round structure with keratinizing cells. Where is it? Show me. Ah, that's right. This is the one. And I would say, and the whole structure, the whole structures. Here there are some. Ah, and this one too, yes. This is smaller. Yes, yes. This could be dyskeratosis, this pink one. You see this pink? Let me show with the mouse. So this is an easily identifiable keratin pearl, indicative of squamous differentiation. And this here may be single cells keratinizing, known as dyskeratotic cells. These both are signs of squamous differentiation of the malignant tumor. The tumor is malignant because it has nuclear atypia and it invades its stroma and surrounding tissues. However, when we see a malignant tumor, we must look for signs of differentiation to identify and name it properly, name the tumor properly. In this case, we see squamous pearls, single keratinizing cells, some cells with quite enough pink cytoplasm, like these ones. This is also a sign of squamous differentiation. And in some cases of very high-grade squamous cell carcinomas, we have to look around the cells, within their borders, from one to the other, to identify what? Have a look here. What connects one squamous cell to the other squamous cells? These are hemidesmosomes in electron microscopy. However, we can see them in properly stained hematoxylin and eosin sections as intracellular bridges. This is also a sign of squamous differentiation of cancerous cells, which is very viable, especially in high-grade tumors, in poorly differentiated squamous cell carcinomas, because in a well-differentiated squamous cell carcinoma, you'll see the keratin pearl. So it will be no need to look for intercellular bridges. However, in poorly differentiated squamous cell carcinomas, high-grade tumors, this could be necessary. And of course, we have some immunohistochemical markers specific for squamous cell carcinomas, the most useful and widely used of which is nuclear staining, immunostaining for P40. P40, all right, along with cytokeratin 5-6 and P63, but mainly P40 is the immunohistochemical marker which stains squamous cells, and in this case, it will be overexpressed by these malignant cells, because these are cells of squamous cell carcinoma. Yes?
I have a question.
Yes.
I don't understand if we do immunohistochemistry or we scan the adenohypophysis first. Like, what's the methodology?
Yes, that's clinical medicine. In clinical medicine, of course, you have to look at the hypophysis. If you have a Cushing syndrome and you see that it is increased cortisol, you have to look. Is the hypophysis all right? The anterior part. Radiologically, it's all right. Then you have to look at the adrenal gland, the gland which normally produces the orthotopic source of cortisol. That means, what's the zone responsible for glucocorticoids production? How is it called? It's glomerulosa, reticularis, and the other is... I must have a problem. I always read the zones, I always forget the zones. I'm angry with myself. I always read that. This is the first zone, the second zone, and the third. The third is for sex, android steroid. The second zone, glucocorticoids. How is it called? It's the glomerulosa, reticulosa, and fascicular. Right? It's okay. Anyway, you understood. It's from the second zone. So you look there. Is there an adenoma in the adrenal gland cortex? No, there isn't. And what do you think next? Before the paraneoplastic syndrome, such as is the case here, does the patient take cortisol as medication? You have to think of that as well. Because if he takes cortisol, therapeutically, he has rheumatic disease, then this will be maybe the cause of the casting. When you exclude all this, then see if there is a tumor someplace, it may have ectopic production of ACTH, and this will cause the patient hypercortisolemia. So, the paraneoplastic production. Have a look here. The serum calcium level is high. And when you see calcium, you always must have measure the albumin. Why? Because a large part of blood calcium is bound to the albumin molecule, and therefore not biologically active, as opposed to free part of calcium. So you have to count calcium, all right? What else do you count, which is reverse, in reverse relations, the values of calcium, phosphorus, and take into account the albumin levels in the serum, because it's important to see the biological active portion of the calcium. So, how can hypercalcemia be justified in this patient? Mainly two possibilities you can tell me. Why is calcium increased in this patient with squamous cell carcinoma? Who can tell me? Two things you must think. Where does calcium get out of and increases in the blood? Where is calcium stored? Where? The bones. So it's either a metastasis from the squamous cell carcinoma and osteolytic metastasis that activates osteoclasts and they lyse the bone. That's why the levels are increased. And also, there is another possibility of an ectopic production of another hormone which has to do with the levels of calcium and phosphorus. Which is this hormone, and where is it normally secreted? Which is this hormone? Arranging the levels of calcium. Remember? Somebody remembers the hormone who is responsible for calcium? Yes. Yes, it's parathormone from parathyroids. In this case, it's an ectopic production. That's why it's a paraneoplastic tumor, because which tissue produces the endocrine molecule that acts like parathormone? However, it is not parathormone secreted by parathyroid glands. It's the cancerous cells. So the cancerous cells can be a source of an ectopic parathormone-like substance, and this may be responsible for the increase of calcium in the patient's blood. Because if he has an increased action of parathormone, this may affect the absorption of calcium from the gut, and also it may take calcium away of the bone and send it to circulation, to blood circulation. So these are the two possibilities. Either the tumor has given hematogenous metastasis to the bones, or the tumor secretes a parathormone-like acting substance. Yes? You remember? Tell me.
If the albumin...
You can send your questions by mail. If
the albumin
the
is high...
The albumin.
If the albumin was high in this case,
we would not be so sure that it is hypercalcemia.
Okay.
Because a large amount would be bound to the albumin molecule, so that would not be active.
But why does it correlate with the hypercalcemia? Because even if we have high albumin, the fact that the calcium levels are high,
Yes.
means that they were released by
It
the bone.
depends what you measure. Do you measure the free calcium, or the whole calcium? Because
Here,
if you measure, I don't know, it's a hypothetical scenario. If I had the patient and I knew what do I use to count the, I would tell you. But always remember that when you say that calcium is increased in the serum, you have to also examine phosphorus in the serum and albumin. Three markers, so that you decide that this is hypercalcemia. Here is another. You see this tumor. It's peripherally, so it won't probably be reached by an endoscope, And since you see that, as we said in the previous lessons, quite a lot of lung cancers radiologically appear as coin lesions. That means they have well-defined margins, and this is deceptive, because they are malignant tumors nevertheless. So what could that be? It could be a hamartoma, it could be a granuloma, as we said in our previous lesson. So how can you take cells from this lesion? Yes?
By needle aspiration.
From the outside. You'll have CT-guided tomography, and you'll put the fine needle, you'll take cells from many parts of the tumor, you'll have the cytologist nearby, and you'll give him the specimen, and the cytologist will make the smear during the procedure, and he'll tell you, it's okay, there are enough cells, I can make a diagnosis, because if the smear is hypocellular, no safe diagnosis can be made. That's why you'll have the cytologist with you. He's a doctor like you. Yes, he's a doctor. He does something. You must cooperate with him. Yes, I know, he's a lab doctor. Yes, that's okay. Not like you. Yes, you're a clinician, I know. But he can help you somehow, because if you take cells and you think you took cells and there are no cells on the slides, he won't give you a diagnosis. No, it won't be his fault. It will be your fault. That's why we'll take him with you. You sit there down as colleagues, not necessarily friends, colleagues. We're not looking for friends in our profession. You look for friends outside. In your profession, you have colleagues. So you cooperate with them so that you do the best, the patient. You cannot do everything on your own. No, cannot. Must cooperate. Unless you have this bad character like me. In this case, you don't cooperate. You do it all yourself. Only you are the best, nobody else. Yes, I know. Yes, okay. So you take cells. You take cells from the lesion. And look, that was an adenocarcinoma. So have a look at the histology. What signs of glandular differentiation do you see? There are glandular structures invading, formed by atypical cells, and you have immunohistochemistry to help you. Why? Because if you see an adenocarcinoma and any other type of lung carcinoma, apart from small cell, this may not be primary. You'll always take into account the patient's history to define that it's not metastatic, because we'll have a look at metastatic cancer, which are the most common type of cancer in the lung, but it has to be correlated with the patient's history, because he could have an adenocarcinoma in the endometrium or in the bowel. That would be the last stage of hematogenous spread of the previous cancer. So, immunohistochemistry may help you, because apart from cytokeratin, which is a marker of epithelial differentiation, this would express napsin A. Napsin A is a marker consistent with primary adenocarcinoma. But that's not all, because it can be expressed in some ovarian tumors, napsin A. So you never make the diagnosis based on one finding. You say, it's napsin A positive, it's primary adenocarcinoma of the lung. No, because if the patient has an ovarian adenocarcinoma history, napsin won't help you. it is expressed in both tumors. So always we make the diagnosis with a constellation of many, many, many findings, and we say they are compatible with this diagnosis. Never have one finding only in your mind. And another thing is the various patterns of adenocarcinoma, apart from the glandular. This is the vilus, the papillary. Many adenocarcinomas may form papillae, true papillae with fibrovascular cores, and this is the mucinous. This is extracellular mucin produced by malignant cells. And can you tell me the difference between this area of adenocarcinoma and this? This is invasive. This is not invasive. What do these structures look like? A normal constituent of the lung parenchyma. Yes. What do they look like? These structures here. These ones. You see, these are the invasive glands. What do these look like? Think of the normal histology of the lung. What do they look like? What is the lung composed of? What do they look like? What is the lung composed of? It has the air and give the exchange, the gas. The alveoli. These are alveoli with normal size and configuration, which, however, they have malignant cells lining them. These are not new monocytes, and this is the lipidic growth of adenocarcinoma, which is most consistent of primary adenocarcinoma. For example, an adenocarcinoma coming from the colon would not make this pattern of heterogeneous spread. So this is lipidic carcinoma, a part of adenocarcinoma, which, however, can be non-invasive, thus termed in situ. This is not the case here, because apart from the lipidic growth pattern, apart from this one, where the lining of the alveoli is malignant cylindrical cells, we have the invasive component of small cells. If that would be the only component of the tumor, you would not be sure that it comes from the lung. You should have a very clear history of the patient before you make the diagnosis. Yes?
The only reason we know that they are not invasive is that because we know that
they have the shape and the configuration of alveoli. They look like alveoli. If you look the normal alveoli, they're like this. However, the cells lining the alveoli are not new monocytes, type 1, type 2. No, they are malignant cells. So this is in situ, lipidic growth. This is invasive. And here we have some other. If we have multiple mass lesions, this could be metastasis either from the ovary, breast, kidney, gastrointestinal tract, but also non-epithelial malignant neoplasms as well, such as melanoma and sarcoma. So how does metastatic cancer look like in the lung? It's either probably multiple masses here and there, but it can also have a pattern, we discussed it the other day, a pattern of lymphangiogenic disperse, and this would make it look like diffuse infiltrates, not nodules. So in this case, you should have a biopsy. So remember that cancer can also have a diffuse pattern, but the most common metastatic infiltration of the lung is this: multiple tumor lesions, some of them necrotic, and this is compatible with widespread metastatic disease of the lung. And of course, in this case, the pleura would be invaded, the fluid would accumulate in the pleural cavity. You could take it and make the cytological specimen and see the malignant cells. Now, our lab's biologist, Dr. Giannopoulou, will now tell us the molecular subtyping of lung cancer, which is very important because based on this, the oncologist gives the chemotherapy. Of course, in non-small cell lung cancer, the first thing you have to consider is take it away, surgical excision. However, sometimes the tumor is too big. It's too big. So you must give some proper chemotherapy, make the tumor shrink, and then you can more easily resect it surgically.